Welcome to those of you here at City Hospital and those of you joining us on Telehealth. We just want to thank you for joining us today. We're looking forward to this presentation and the opportunity to ask questions. My name is Todd McPherson. I'm the Executive Director of Parkinson's Society Saskatchewan, and we're happy to present this event to you today and looking forward to the conversation that follows. Well, it was an excitement for us when Dr. Vitali contacted our office and said he'd be happy to speak and to share with you and talk about deep brain stimulation and just the experiences and what you can possibly encounter through that. And of course, it's a very important subject for many of you, and I know some of you present have already had that experience. So allow me to give a little introduction of him. Dr. Vitali has been a clinical assistant professor at the Royal University Hospital, University of Saskatchewan since 2007. He completed a functional neurosurgery fellowship at the Surgical Center for Movement Disorders at the University of British Columbia in 2006 and a pediatric neurosurgery fellowship at British Columbia's Children's Hospital in 2007. Since his arrival at RUH and U of S, the functional neurosurgery program has been able to achieve considerable growth. He started the deep brain stimulation program in March 2013, and this was further expanded with the arrival of Dr. Ivor Mendez. Dr. Vitali has special interest in all aspects of functional surgery, including deep brain stimulation and pain management. It is a privilege to introduce to you Dr. Alexander Vitali. Thank you.
Thank you. Thanks. Good afternoon, everybody. I'm not sure, can you hear me well enough? So it's my privilege to be able to talk to you today, and I will try to do my presentation as quickly as possible so you will have a chance to ask questions. And towards the end, I'm hoping if everything works well, I will be able to show you a couple of videos. So I'm one of the neurosurgeons at RUH, and as it was just said, my special interest is deep brain stimulation and functional neurosurgery. But at the moment, I also do pediatric and some spine. I'm hoping to downsize, but at the moment it's not possible. Everybody probably knows what that painting shows. I just wanted to point that skull has a little bear hole, and Hamlet is holding the electrode, the deep brain stimulation electrode, so to make it relevant. So those are objectives. I'm hoping to explain to you what's a deep brain stimulation, how we're doing it, what are the risks and complications. I'm not going to try to sell you something. I'm not going to tell you only good things and keep the bad things away. And I would like also to talk about selection, how we look for the patients who might be good candidates, and then how we take them through the assessment and preparation, and then what to expect in the end. I will also show you 3 or 4 slides about stem cell transplant before you will ask me questions. I know many of you probably have seen recent media interview with Dr. Mendez. So just to make it easy, I include a couple of slides at the end. So first of all, what is deep brain stimulation? In short, DBS, and I will be using it all the time, so you know what I'm talking about. It's basically electrical stimulation of deep parts of the brain to improve or to treat movement disorder, among them Parkinson's disease. And this is done through fully implanted system, which consists of electrode, extension cable, and a battery. And this is the diagram which shows you where that hardware is inserted. And this is actual picture of the deep brain stimulation electrode with extension cable and the battery. And that's how it looks on the scans and x-rays. This is a skull x-ray of the electrode going into the brain and the cables being tunneled under the skin down to the chest. Those are the electrodes on coronal MRI scan, and you can see here electrode on axial pictures. So this is subthalamic stimulation. This is the stimulation for Parkinson's disease. how did all started? How did it happen? Well, it actually comes from two different parts of medicine. First, neuromodulation, where scientists, doctors try to stimulate the different parts of the brain to see what happens. Well, if we stimulate, which part moves, but also for better anatomy and for treatment. And then the other part, which is called stereotaxy, when they try to localize the lesions within the brain. So if you can imagine skull as a sphere with the brain being inside, we can actually calculate and target any point inside of the sphere. From that, when they put those two things together, they were able to do the lesioning. They would put the electrode in the brain and burn part of the brain which was malfunctioning and causing problems, Parkinson. And from that, the next step was stimulation. So although there are some anecdotal reports of movement treatment of surgical treatment for movement disorders in the 19th century, the actual treatment started in the mid of 20th century. And then in 1968, disaster happened for surgeons, that levodopa became available, and all the surgery stopped. Everybody was treating all movement disorders with levodopa until it became clear that levodopa is not the wonder drug. It does not help all the symptoms, does not help all the patients, and it does have side effects. And then with technical development, with availability of CT scan and MRI scan, as well as smaller implantable stimulators, now that's how the deep brain stimulation or neuromodulation really took off. So what are we stimulating? Well, those are the targets in the brain which are recognized for the stimulation. So right in the middle of the brain, so it won't be too easy for us, there are structures which we called basal ganglia. Those are clusters of cells which are interconnected, which control, modify all the movements. So 3 of those targets, thalamus, globus pallidus, internal part, as well as subthalamic nucleus, those are recognized targets for the deep brain stimulation, and those are the years when it was actually recognized. Thalamus is a big group of different nuclei, so we put the stimulator in ventral intermedial nucleus of thalamus. And then if the symptoms of Parkinson's disease respond to levodopa, as it happens in most patients, the subthalamic nucleus, STN, is the preferred target. But if those patients have not only motor symptoms, but also severe motor fluctuations, then GPI is considered even better target. However, if we're treating and if we're concentrating only on tremor, then we would target thalamic nucleus, the VIM. There are some other areas which are being investigated, and there is some evidence that, for instance, pedunculopontine nucleus stimulation improves gait and balance, but this is not available. This is still more research and experimental treatment. So what's STN, that's subthalamic nucleus? Well, it's about 500,000 of cells, size of the peanut, right at the base of the brain. So it is close to the center. This is thalamus, the subthalamic nucleus, it's here. And it controls not only movement, but other functions as well, or it's involved in modulation of other factors. Luckily for us, the part which controls movement is the biggest, so it's easiest to target. How does it work? Well, we know that high-frequency stimulation, over 100 hertz, mimics the effects of lesioning. So basically, it turns the cells in that area off. How exactly it works, we don't know. Maybe by stunning them, by blocking the signals or modulating other cells. activating other cells, or maybe even changing the blood flow. Most likely it's a combination of different factors which we still don't fully understand. And this looks like a very complicated diagram. You don't have to remember that, but it shows you all the basal ganglia and connections, how they are connected in the normal situation. So in a person with a Parkinson's disease, that's where the problem starts. Okay, substantia nigra does not produce enough dopamine, and that changes the whole circuit. The bottom line is that the subthalamic nucleus is hyperactive, and the same is globus pallidus. And it causes blockage of the signals to the thalamus, which is supposed to send signals. It's like an intermediate station for signals going to motor cortex, which actually initiates the movements. So if we stimulate those two areas, we basically restore, or trying to restore, the distal part of that pathway to reset it to relatively normal function. So how does it work for the patient? Well, in early Parkinson's, they spend relatively little time with bradykinesia, with problem with movement. And with levodopa, they function fairly well most of the time. What happens with advanced Parkinson? Well, the levodopa frequency has to be increased, and the patients move almost immediately from inability to move to uncontrolled movement, dyskinesia. So basically, they spend less and less time within a normal range of movement, and this is called on-off fluctuations. So what does happen with the subthalamic nucleus? It's like taking the patients back, taking them and moving back in time, 5, 10 years, depending on the disease progression. Okay, and that's how stimulation restores. It mimics early stages of the disease. Why are we stimulating? Why did we stop just putting the needles and burning the brain? Well, it's reversible. We can adjust it to increase the effects and reduce the complications. We can do it bilaterally with lesioning. You can see here. So this is basically a scar in the brain, a person who had lesion of globus pallidus for Parkinson or some other movement disorder. We couldn't do the lesions on both sides because it will cause other movement disorders. But with stimulation, we can do it. And it's very reliable. With the details which we give to engineers, they can exactly calculate the electrical field. They can tell us what we're stimulating, what we're actually doing. There are disadvantages, including the cost. The stimulator, the whole system costs probably about $20,000. But if it works well, after a while, it pays off because of reduction of medications or reduction of hospital visits. It is a foreign material which we're implanting, metal and plastic. It requires initially much more time and effort to do the programming and do the surgery than just putting the needle and burning part of the brain. There is always small risk of equipment failure. It's a mechanical system. Okay, so it's got a battery, cable, electrode. Cable, electrode can get broken or move. Battery can fail. Also, the batteries have to be replaced on average every 5 years, but that depends on how much energy is being used. How are we doing it? I hope this is the most important part. I will show you some pictures. Those whose stomachs are a little bit weak, just relax, sit comfortably, or maybe we should distribute a couple of paper bags. So surgery consists of 3 stages or 3 phases. The first one is to implant the electrode. That sounds so simple, but this is actually the most difficult part and the longest part. If the whole surgery takes 6 hours, to put the electrode takes probably between 4 and 5 hours. Okay, and then once the electrode is in place, then we would insert the cable and the battery, and then the third phase, it's adjustment. Luckily, that's now more neuromodulation nurse coordinator who works with me than me, but I have to be involved as well. So this is the frame. So this is the frame which we would put around patient's head, and those are the pins which will attach the frame to the head. So it's basically 4 pins which will go through the skin into the bone, but we would give freezing to prevent the pain. So 4 injections, and then the frame goes. Then this box goes over the frame. I call it a phase box because this is a localizer. The CT scan or MRI scan will see these bars, and actually that's how we calculate the target with reference to the frame. And once that is done, we've got the other parts of the frame which gets attached to the base, and that actually will take us to any place inside the brain we want, as long as we know how to calculate it. The whole frame which goes on the patient's head will be here. For the time of surgery, it looks like this. So this is just for scan immediately before surgery. Then we do our settings, and then we put all of this, which is maybe about 1 kg, maybe 3 pounds, on the patient's head. And this is example how it looks in practice. So this patient has a frame attached to his head with a box and is ready to go to MRI scan. And if he's able to stay still, we have pretty good picture, and we see all those markers around the head. So we've got a computer which will calculate our target, because we know where subthalamic nucleus is, and if we don't know, we shouldn't be doing it. But if we know, then with reference to the frame, we can calculate exactly up to the 1/10 of the millimeter where our target is. Then we've got more sophisticated machines which will calculate. We have also some residents which are very good for posing for photographs, not necessarily good to help with that, but you can see the whole machine where we actually look at the brain and decide our approach. So that way we can avoid major blood vessels, like on the scans, and we can avoid fluid spaces, the ventricles. So we would follow the whole trajectory. That way we choose the safest way. And once we've got our target and trajectory, we have to set all those coordinates on the frame, and it will point us exactly where the burr hole is supposed to be. So then we would give freezing, make the skin incision about 2 inches long, maybe 6 centimeters long, and then burr hole. Once the burr hole is done, then we set up the rest of the system. And here you can see the electrode going into the brain. Now, in case I forgot to mention it, this is done with the patients being awake, because the brain does not feel the pain, so we can do whatever we want with the brain. The problem is skin. So for skin, we can give freezing, the same like dentists. And then we drill the burr hole, which is much louder than the dentist drill. So we advise the patients not to bite their teeth, but it lasts only a minute, and it's less painful than the dentist drill. Not that bad. And then there is more equipment. So this is the micro drive, which actually will push the electrode into the brain, and it's accurate up to 1,000 of millimeter. And this is all controlled and connected to the computer. So there's a lot of setup. This is the computer system which would record the brain activity, and through that we can stimulate. So as the electrode goes into the brain, different parts of the brain will have different electrical activity, and we record it. So this is the first way of being sure that we are going to the right place. And through different layers, we go until we get a recording, which is very characteristic, and we know this is subthalamic nucleus. So the recording is done through the microelectrode, with a tip being couple hundreds of millimeter in size and can actually record single cell signal. And when we think we're in the right place, we just withdraw the microelectrode, and through the macroelectrode, we would stimulate. That's why we need the patients to be awake, because we would look for symptoms of Parkinson, in this case, stiffness, rigidity, and or problems with movement, because the patients are off the medications. But we're also looking for side effects, like the muscle contractions, abnormal eye movement, and abnormal sensation. So we, most of the time, Karen communicates with the patient. So this is the second way to be sure that we're in the right place. Actually, the third way. The first, we do the scans and we calculate and we set up our equipment. The second is recording. The third is stimulation. And if the patients don't have side effects and their symptoms improve, then we would implant the permanent DBS electrode, which you can see on this picture. It's about 1.2 millimeters in diameter. And this is X-ray, which is done through and through the frame. So you can see our stimulating electrode, and then it's being replaced by the deep brain stimulation electrode. Depending how big area we need to stimulate, we've got close and wide space contacts electrodes. And then we cover the burr hole with a cap, which will cover the skull defect and also keep the electrode in place. We're actually using a hard plastic system now, which looks much more intimidating. And then when this is done, so that part takes about 4 hours for 2 sites. And for many patients, that's probably the hardest thing. When that is done, we take everything. We take the frame and everything. We put the patients asleep, and then we do stage 2, which basically involves pushing the cable under the skin from the scalp incision onto the pocket, into the pocket just below the clavicle where the battery will be inserted. And then in programming, one would think, okay, we've got only 4 electrodes, so how difficult it can be, but there's actually multiple different parameters which we can program. So number of combinations is very high. Karen may know exact number, I don't know. And then follow up. So when we do that, we check everything in operating room. We check that everything is connected. We check for side effects. And then we turn it off. And we send the patient home for a month. The reason being, I told you, the STN is like a small peanut at the base of the brain. So plunging that electrode, even though it's just slightly bigger than 1 millimeter, through that nucleus, through STN, improves Parkinson's symptoms in many patients because of a little bit of swelling and maybe a little bit of bleeding, maybe a little bit of inflammation. So then they say, my symptoms are better. I don't think I need the stimulation. Maybe we should take it off. Once everything heals, after 2 or 3 weeks, the Parkinson's symptoms will recur and they will be basically the same as before surgery. So we wait through that time, and then we bring the patients to turn the stimulator on about 1 month later in the clinic. And then it takes a couple of visits for fine-tuning. And also, most patients will reduce their medications. So that will also require adjustment of the stimulation. We need to educate them. We need to tell them what they can, what they mustn't do. They get a controller like this, so they need to know how to use it. And after that, if everything is fine, then we would just see them maybe once a year to check the battery. And we will be able to tell when the battery is near end of life and needs to be replaced. And also we can do it, we can tailor it for patients' needs. We can just do single electrode, just one side, if the Parkinson's symptoms are mainly on one side. We can do it staged. Say we put the electrode, we're not sure if it's working, we're not sure if it's causing side effects. We don't have to do stage 2. We can take the patient to the ward, we can stimulate for a couple of days, and then bring them back and do stage 2. That slightly increases risk of infection, so we don't do it routinely, but it's an option. we can have one system, we can have 2 electrodes with completely 2 different circuits, one on each side. So, and also we do have rechargeable batteries, but most patients actually don't like them. And we would offer them only if the original battery would be exhausted after less than 2.5 years. But even a rechargeable battery is the same like batteries in the cell phone. They lose their capacity, and they have to be replaced after about 8 or 9 years at the moment. Apart from that, so this is the frame which I showed you. This is the frame which I'm using. And this is the frame which Dr. Mendes is using. But some patients may have very big heads which won't fit inside of those frames. Well, we have a portable, disposable system. This is basically a frame which gets attached to the patient's head. But to do that, we also have to put several pins in the skin. And those are the pins which are being seen by MRI scan and our computer. So this may look much better, but one ends up with many more holes in the scalp with that system than with our standard frame. And although I'm here and I really feel privileged that I can talk to you, the whole team works with those patients. So Karen is Karen is our neuromodulation nurse who looks after all those patients, and she spends hours adjusting and doing programming. And also she helps me with all the equipment because I have no memory. I don't know the names and the numbers, and if she wouldn't be in operating room, I probably would do half of what I'm doing simply because I'll be checking the equipment. So it's a teamwork. But if something goes wrong, surgeon always gets blamed. But it's a teamwork. Okay. And there are complications. Okay, so not everything is going smoothly, as I just showed you on those pictures. Any surgery has a risk of infection and bleeding, and deep brain stimulation is not different. So the infection rate is actually recognized between 3 and 8%. I think ours is on the lower side, might be, 2-3%. But we would cancel surgery if the patient was sick, if there are some skin problems, just to decrease the risk of infection. And bleeding is 1% per each electrode pass. So if we're doing both sides, it's 2 times 1%. If sometimes we have to take the electrode, reposition, and put it in again, that slightly increases the risk. Now, we're talking about most of the time minor bleeding, not the bleeding which would cause blood loss and require blood transfusion or put person's life at risk, unless it's a stroke. And stroke is the most serious complication of deep brain stimulation. The risk of bleeding is about 1%. The risk of stroke is about half to 1/3 of that. And again, stroke can be minor to severe, including coma and paralysis. So the risk of stroke is about 0.5% to 0.3%, but this is the worst complication which can happen. And then all the other bad things which can happen, the side effects from the stimulation, like tingling and muscle contractions, and abnormal movements. We can work around that by adjusting the stimulation. Many patients may have, or it has been reported, that they have psychiatric problems, and this I will revisit when I'll be talking about patient selection. And then there have been reports of patients deteriorating, their cognitive function deteriorating after deep brain stimulation, and then technical malfunction. That risk is about 1.5%. That's estimated by the manufacturer who makes those devices. And most of the time we can figure out what's not working and repair it, but that means surgery. It means going back to operating room and replacing part of the system. I was talking about psychiatric problems and mood. There are many reports of these problems in relation to deep brain stimulation. It does not happen often, and it's usually, it also may be related to medication. So with a medication change, it may improve, but it is usually in patients who did have some kind of psychiatric history. And again, that will bring us to patient screening and selection. Now, one thing we know, that DBS, ST and DBS, if it's a little bit too deep, interferes with ability to slow down and make decisions. So if you have a relative who passes through surgery with flying colors, don't take them to Vegas. Because there have been reports of patients with after DBS going and losing significant amount of money. Okay. Another thing, you may have heard, risk of suicide after DBS. Well, it's true. Those are the risk factors which are listed on that slide. And it is highest in the first year. But after looking at all the studies, it was actually 24 patients out of almost 5,500. So the risk is less than 0.5%. And I don't know, I'm not a neurologist, I don't know what's the risk of suicide in patients with movement disorder without DBS. When we're talking about outcome, everybody is talking about different things. The patients talk about they want their non-motor symptoms to improve, versus doctors who looking mainly at motor symptoms, tremor, rigidity, and then for health authorities, outcome is a completely different story. So what does get better? Tremor, rigidity, bradykinesia, dystonia. So all the motor components do get better, or should get better if the surgery is done properly. Gait and balance may get improved if it responds to levodopa. Otherwise, it doesn't. Okay? And unfortunately, autonomic dysfunction does not respond to deep brain stimulation either. Usually, most of patients have pretty good outcome. I would say the success rate for all those targets is about 90%. For tremor, might be even higher. For VIM, it might be even higher. And we see that in our practice as well. So I showed you all of this. You may ask, okay, does it really work? Well, there's more and more evidence it does. It really does work. We know now that it is better than medical treatment for control on-off fluctuations in moderate and advanced Parkinson. And this article came out in 2006, 156 patients with severe motor complications. Neurostimulation was more effective than medical treatment alone. Another study, 255 patients. DBS was more effective than the best medical treatment with improving on time, motor function, improving quality of life, but it was associated with increased risk. And another trial, 366 patients from June 2010. At 1 year, surgery and best medical treatment improved patients' self-reported quality of life much better than medical treatment, but surgery had slight higher risks. Okay, so what happens when DBS does not work? There are studies looking into that as well. Most of the time, the problem is with stimulation settings. So luckily, that can be sorted out. But between 10 and 30%, the DBS did not work because it was done to wrong people. So inappropriate patient selection. And that's where I'm concentrating. That's why it takes so long from the moment to see the person to decide if we would offer deep brain stimulation. Unfortunately, in some cases, we can't do anything because it's just a natural disease progression. And then there are some issues with hardware and malposition of the lead. Almost 3/4, those are reversible factors. There was a study which looked at DBS failures in all movement disorders. And why they think that it wasn't working? Because of problem with preoperative screening. Almost just over 1/4 patients didn't even see movement disorder. They were offered deep brain stimulation. 12% didn't even have a proper medication trial. Only 1/3 had neuropsychological testing, and basically 1 in 9 had already dementia or early dementia when the DBS was done. Surgeons are at fault as well. Almost half of the leads in that study were malpositioned. Many patients did not have access to the programming. They had a DBS and then they were sent and look after their device by their own without teaching, without programming. And many did not have medications adjusted properly. So in that study, more than 50% patients of failed DBS actually improved when all those factors were looked into. So what we do when we have a patient with a failed stimulation, we'll start from the basic. We check the impedances, we check the battery, then we would check if the electrode is in the right place. But with scans, we would do X-rays to be sure that the electrode or the cable is not disconnected or broken. We will try different stimulation if we can't find anything else. Sometimes we would even consider putting an additional electrode. After listening to all of that, and if I did not scare you, some of you might be asking, am I a good candidate for a DBS? Well, let's see. We used to tell everybody, especially neurologists, that only about 1% of Parkinson's disease patients would be candidates for deep brain stimulation. Well, that has changed now. Now we think between 10 and 20%. Probably even more, but we can't tell that neurologists because they will stop cooperating with us. So ideal patient, Parkinson's disease symptoms with motor fluctuations and or dyskinesias not controlled with best medical treatment, or Parkinson's disease with medication-resistant tremor. No psychological or psychiatric problems, and no medical problems which would make surgery more dangerous. For instance, patients on blood thinners, patients who had a recent stroke or heart attack. Patients who had at least 5 years of Parkinson's disease, to exclude Parkinson plus syndrome, which might be because side effects of some medications, relatively young onset Parkinson's disease, and in many places the cutoff for the age is 70 years. I don't think it's right. I've seen 70-year-old person who was healthy and fit like 55-year-old. We would not withdraw surgery based on age alone, but the general medical condition is important. And so, as usually, most patients actually fall out of all the categories. So there's no very difficult to find ideal patient. There is some indication that those who require very close medications doses and patients who want to maintain work, they would be a good candidates for DBS as well. If one looks at the staging of Parkinson's disease, the best would be grade 2 or stage 2. But actually, depending on the symptoms and depending on general medical conditions, we may offer to anybody who's within stage 2, 3, or 4. How do we screen those patients? So now they've been referred, okay, because Dr. Vitali did not scare them with his talk. So first of all, is it Parkinson? If it is, how long? What's the age of the patient? Again, what's the medical condition? Any problems? Then we look at the motor symptoms, and there are motor symptoms which we call unfavorable, so-called red flags. So this is the list of motor red flags. Those patients won't do well. We shouldn't be offering DBS unless there are some exceptions. And then non-motor symptoms. Those patients won't do well either. So again, we need to screen them. We don't want to do surgery if we can't deliver what we're talking about. Next thing, we would bring the patients and we would do video. We would film their response to medication. And basically, we stop all the medications for 12 hours. Then we do UPDRS scoring, Unified Parkinson Disease Rate score in off state. And then we repeat it after they've taken their medications. If there is more than 30% improvement, so the total scoring should go down, those are good candidates. Some of those who improve less than 30% but have those symptoms, they might be candidates as well. So this is, again, this test has to be taken in context of all the others. We would look for medical condition. And you may ask me why. Well, one, the person has to be strong enough to withstand 4 hours of local anesthetics and sleeping on the table with the head fixed to the frame. Another example, I remember a patient from Vancouver who had a DBS for Parkinson, and he felt so good that he was going for a long distance outdoor swimming, which he didn't do for a couple of years because of Parkinson, and then he had a heart attack. He survived, but we don't want our patients to go through that. In the end, we would evaluate every patient based on their symptoms and risks and complications. Neuropsychological assessment. All the troubles start with if there was unrecognized or there was a past history of psychiatric or psychological issues, or early dementia, which is not recognized. So again, we don't want to hurt those people. We would assess them. And we've got a neuropsychologist on our team. Imaging. We need to know where we're putting the electrodes. One, I don't want the brain tumor or some bundle of blood vessels where I'm putting my electrode, because almost then the risk of bleeding and stroke will be much, much higher. But also brain atrophy. Remember those scans I showed you, the burr hole. So if there is a brain atrophy, the brain will shrink. Nature does not tolerate vacuum. That space will be filled with a fluid, which usually accumulates on the surface of the brain. We do the burr hole, cerebrospinal fluid will leak out, the brain will move, and we lose all our registration or all our marks. We can't get electrode where we want with that. And then, of course, again, we'll discuss expectation. We're not selling cars. We're not promising things which we can't deliver. We'll explain the surgery in details, kind of like I explained it to you, and then follow up. They don't get the deep brain stimulation, and they wave to us and say goodbye and go away. It doesn't work that way. We want to be safe. We don't want to do something like that, but we don't want to overdo things either. Okay, I promised you a couple of slides on cell transplant before you ask me. So that was actually tried in 70s already, and then in mid-80s they tried to transplant adrenal medulla cells into this is part of basal ganglia. This is one of those nuclei ganglia. And then, if I remember correctly, there were 5 articles which described several patients. 2 patients showed some modest improvement, and that stopped everything. And then end of 80s, they tried fetal cell transplants. Problem is, we still don't know which cells are the best. Those are different types of cells which we tried. We don't know exactly where to put them. There are several basal ganglia, and almost any of them can be targeted. So what cells are we supposed to use? Where are we supposed to put them? And even if we decide on the cells, how do we obtain them? Do we multiply them? How much it's going to cost? Then, how do we put them exactly where we want them? So whatever video interview you've seen with Dr. Mendes, that was about the robot which will deliver cells into the target. This is just another toy, which is supposed to be more accurate than what we do by freehand, but it's only as accurate as the person who puts the program and then controls that, and as accurate as the scan which is done and is downloaded on that computer. So even though there is a new toy, that does not sort anything, does not help with anything. We don't know how long those cells survive, how many of them survives. That's where Dr. Mendes did some work in Halifax on that. We know that just injecting those cells causes side effects. In the long term, can cause probably also brain tumors. We don't know enough about them. We don't know about efficacy of the graft. And even if it is, the cells stay there and they survive and they produce dopamine or whatever, how that translates into the clinical outcome. We have no idea about any of those things. So this is still experimental treatment. There is a trial which is actually going in Europe since 2009. So in 2009, they recruited 150 patients with Parkinson. They've been watching them for 5 years for their progress. This year, they started implanting the cells. I think they use fetal mesencephalon cells. So the cells which have been used in the past, they just have much better way of obtaining that and better protocols. So they're going to graft 20 patients. 20 patients will have a sham surgery, so they will put something, but it won't be the cell transplant. And then they're going to assess them, and they will compare to 110 who will not be offered surgery. And by 2018, they expect to have maybe some results. Okay. I think there are similar plans in America, but I couldn't find any references. Also, one has to remember that even if it will work, it may work only for patients with early disease, where we can do some interventions on the cellular level. But as disease progresses, the patients have more and more motor disabilities, and at the moment, DBS is the only proven treatment, and then medical treatment throughout. And just to show you about our experience before I showed you videos, which I promised. So I came here in 2007. 2008, we were ready to do the first deep brain stimulation. We had expertise, we had all the equipment. There was no money. So in 2013, finally we did the first one, about 6 months before Dr. Mendes came. And I think we did 2 or 3 before he came. And until that time, we had 2 or 3 patients which were implanted elsewhere, but we looked after the stimulation. We changed their batteries. Since 2013, we think we'll have about 60 patients by the end of this year. That's including mine and Dr. Mendes. And now I'm hoping to show you some videos. So this is gentleman, 62-year-old gentleman with Parkinson's disease, and that's without medications. We stopped his medications for the trial. So video might be not the best quality, but we don't have bigger rooms at RUH. So. So I think that the most significant will be when he will be trying to get up just now and make a couple turn and couple of steps. That's where he froze to the floor, and then with a couple of steps he managed to turn. This is the same patient 1.5 hours later after he took his medications. So he seems to be moving better, but now he's got also some uncontrolled medications and at times also some dyskinesias, which he can't control. I try to not to show his face, but since that time, actually, I have a permission to show his face. So I apologize if at times you can't see his hands, but we work it out. So that was with medication, and he was taking about 10 levodopa tablets per day. Next slide. This is the same patient about 6 months, 3 months, 3 months after implantation. He cut his medications from 10 to 6, and probably will cut more because this is quite early now. Okay. There was not enough space in the room, so we just took him out to show he's walking. It's basically normal. He has no freezing. And so knowing what you know now, would you do the surgery again?
Absolutely.
What you did not like about the surgery and the whole hospital visit?
It's maybe a little bit too long, that surgery.
Okay. What was better than you were expecting?
The results, I had no idea whether I was going to be one of the lucky ones that where it was very effective or whether it would, like sometimes they say in the books that sometimes people get other symptoms come up, and when the ones that they had go away and new ones appear, more dyskinesia.
And unfortunately, I don't have a video or preoperative video for this gentleman, a 61-year-old gentleman who had DBS about a year ago. He was on 11 tablets of levodopa before surgery. After surgery, he is taking 1 or 2 tablets. So this is almost entirely just with the DBS. And as he says, half of the time he forgets to take those 2 tablets anyway. Okay, now if you can, and a couple of makeup. And again, I ask him, so knowing what you know now about DBS, would you do the surgery again?
Yes, I would.
Okay. What was the worst thing about the surgery and the hospital stay you experienced?
Getting the freezing put in my head.
So the worst was when we put the freezing in his head. After that, the frame for hours didn't bother him. What was better than you were expecting before surgery? Which part of the surgery was better or easier than you thought it will be?
Everything else was not easier than I thought it would be, actually.
Okay. So that was the only complaint he had. So I hope with these presentations you guys will understand better what we're doing, and there will be no misunderstanding between expectations and what we can deliver, as you can see on these pictures. And some of the slides which I used are from Dr. Hani, who used to be my mentor in Vancouver, as well as from Medtronic. And I wanted to thank my patients who agreed to be on those videos, Dr. Kindrachuk, who did all those videos, embedded them in the presentation, and Karen, who reviewed my presentation for grammar and English. Thank you. Well, we know that DBS causes some interference on ECG, and I would guess on EEG as well, but remember they can be turned off. The patients have controllers and they can turn them off. After something like a CPR, if the person is okay, the whole system would have to be checked, I guess, before turning it on. And theoretically, there would be a small risk of damage to the system. And theoretically, there might be a small risk of burn along the hardware. But personally, I have not seen any reports like this or any information about that. So the question is, if we stop all the medications before surgery, we stop the medications when we do the trial, the video, to assess the improvement, and then on the day of surgery, one is allowed all the other medications, but not Parkinson medication. We want our patients to be stiff, because you can only imagine if they do have dyskinesias, and they won't stay still in scan, first of all, and then they won't stay still in the frame on the table. And then as soon as surgery is over, we restart the medications. I'm happy to review as many referrals as I will get. I'm not promising that everybody is a good candidate. The problem is how many operations I can do, because unlike Dr. Mendes, I do all the other neurosurgery as well. And at the moment, realistically, I can probably do one deep brain stimulation per month. At the moment, we've got about 10 patients who are being worked up. And all the testing, like neuropsychological testing, MRI scan, and then clinic visit to do the recording and testing, I think we can do everything within 6 months. And then after that, we know if the patient is a good candidate or not, and then surgery can be offered within a month or two. So I think probably about 6 months. Once we meet in the clinic, and after initial meeting, we decided that that person is still interested, going through all of this, what I showed you, and I think that person is a good candidate. There are no immediate red flags or major medical problems. Autonomic dysfunction. Well, things like sweating, problems with the blood pressure, especially with the changes in the position, things like that will not, bowel problems, things like that will not get better with deep brain stimulation. Deep brain stimulation is treating movement symptoms, the motor symptoms. They don't disqualify you as long as we've got realistic expectations and there are no other red flags. I just don't want to offer deep brain stimulation to someone who's concentrating on their walking when I'm not sure if I can help. But I can help with rigidity, with tremor. I can help with dyskinesias.